for the great toe. I want to see you guys come in here. You're finding the joint, right? When you have that, you can stabilize above on the metatarsal, and then you get on the phalange for the AP glide. Okay. Now, which side is the MCL and which side is the LCL? This is the medial side, right? And this is the lateral side. So this would be my valgus, okay? And this will be my varus. You can stabilize up here to do your valgus and your varus, okay? So that's how I want to see you do valgus varus. It's just difficult to kind of come in here and, like you would with a knee, right? So if you just stabilize above, you can do that valgus varus. So that. Okay, so our anterior drawer, we said our ATFL lives right here. This would be, we're in neutral position like so. And so we want to plantar flex her a little bit to get her joint not to be closed packed. If I take her all the way into dorsiflexion, I've closed the talocrural joint in complete dorsiflexion. This is neutral. I open her up, and we're eyeballing 10 to 15 degrees. Get them nice and relaxed like so. This would be the wrong hand placement, right? This is my hand placement that I want. I'm gonna stabilize here. I wanna look right here, and then I'm just gonna pull along the line of my hand, okay? Along the angle that I have her whole plantar surface of her foot. I'm just gonna pull like that. Now, in order to do my inversion tailor tilt, I can just take my hand, pull her up into neutral, and then rock it inversion stress test right there, okay? So I had her down here in about 10 to 15 degrees. So I think in the book it even mentions 20 degrees plantar flexion. I do my drawer, I bring her up here into neutral, try to give some axial compression where I'm gonna lock that subtalar joint to make sure that it's closed, and then I'm gonna stress my calcaneonavicular ligament. Then to do my external rotation, I just move my hand, right? I've got my hand up here. In the book, remember I said they like to use their forearm like that, but I don't like to do that. I like to put them in a neutral position here, and then I'm gonna externally rotate. If I'm in neutral, I'm looking more for the deltoid ligament. If I close pack her up here like this, and then turn, more syndosmotic, okay? Meaning, my mechanism of injury is usually like this, and then someone falls on me. So I go into external rotation. So you want to put them back into that mechanism that they got hurt on, okay? Keeping in mind, we have a lot of plantar flexion, inversion. We can still get high ankle sprains. It doesn't have to be set in stone that it's external rotation for the syndosmotic sprain, but you can see if I'm maximally dorsiflex and I externally rotate, how this is going to splay out, okay? Because whenever they go in this direction like that, external rotation, it's just going to split that apart, okay? So that's the angle in which we want to do it. So anterior drawer, I've exposed the ATFL, 15 degrees plantar flex, drawer. Up into neutral, close it, inversion tailor tilt. Switch my hands. I have them in talocrural neutral, external rotation test, dorsiflex, external rotation test, Kleigers, deltoid, syndosmotic. Move my hand down, my hand placement stays the same. I've got her in neutral again, and then I'm gonna do my eversion tailor tilt, looking at the deltoid specific, okay? Then I come up here and I just start at the proximal fibula, squeeze, and I'm working my way down to the syndosmotic, okay? So I can use my squeeze test for fibular stress or fracture and syndosmotic, right? Then the tap or the percussion, does this hurt? Yeah, it hurts, okay. All right, so that is the bump test or the tap, and they call it percussion, different things. Now, medial tibial stress syndrome, we said, I started in on that yesterday. We've got our tibialis, or our tibia here, our tibialis anterior comes here and comes across. You'll see a lot of shin splints that happen just on the lateral side of that tibia. Quite honestly, I like those. If I've got it, and it's not on the bone, but it's on this muscle right here. You'll get that a lot in your younger athletes. Let's say you're working with a football team, then they switch over and they start playing basketball. Or you've got a volleyball athlete that switches over and starts playing basketball. Soccer. Or any of those where they're changing from grass to court or something like that. And I can remember as a kid, I would get these shin splints over here. It was on the muscle. It's just getting used to something different. Run, jump, start, stop, as opposed to, 5 yards in the cloud of dust type deal. Okay? So shin splints out here are okay. When you start getting them over here, okay, on this medial tibia, starts taking on a different meaning for us. If it's over a large area, we like that much better than more focal area. The more focalized it becomes, the more we worry about a stress reaction. The other thing is if they're sore back here on the back, and we call that periostenitis. So there's a periosteum that goes around the bone. And then we've got this large calf muscle back here, right? This gastroc that can pull away and irritates the periosteum around here. And we'll usually call it, that is called medial tibial stress syndrome. It just depends on what it's coming from. So I could be showing a stress reaction in the bone. We hope that it doesn't get real focalized. I could be having just some soreness back here as it gets back on the back side, periostenitis. Okay, so it just depends. So shin splint over here over tibialis anterior is one thing, and they typically with MMT, pull back and hold, are not going to be sore there, but at the touch they will be. Okay, all right. With the shin splint on the medial side, we want it to be over a large area and not focalized. And if they start getting sore back here on the back, that's more periostenitis. Now we also know that a big area for us as far as over tight is going to be this tibialis posterior right here, and sometimes you can see where they are super sore kind of right here at that junction right there where the sole is, and then it kind of goes into the tibialis posterior. You could work on that day after day after day, kind of like this lateral gastroc in correctives with them. Okay, so if you're seeing some lower extremity type stuff, Achilles, plantar fasciitis, you can work those to work on this dorsiflexion here. Remember the lecture we had on that tibialis posterior, it gets worked pretty hard, a lot more than you think. Okay, so my medial tibial percussion is whenever I have this pain over here, and I'm just going to start tapping. So similar to my squeeze test, as I'm coming down like this, I'm going to take this medial side of my tibia and just start tapping like that, okay? And looking for focalized tenderness. And if I find a spot, and they're going to be apprehensive too. They might grab your hand and they don't want you to tap there. So you're going to start proximal and move distal down the shin like that, looking for focalized tenderness, okay? That's medial tibial percussion. Now, what is Homan's test and Pratt's sign? Do any of you guys know that? Have you ever heard that before? So what we're worried about with the Homan's test or the Pratt's sign is we're worried this is an athlete that has sustained a big time injury or their post-op, be it hip or knee, and we're worried about them having a DVT, a deep vein thrombosis, which is a blood clot, okay? So we have these athletes, I've seen them get these post-injury and more commonly see them get these post-surgery. So there's things that predispose them to that. So all of our females that go in, if they are on any type of birth control medicine, what they'll usually do is prophylactically put them on blood thinners. And I believe you have to stop the birth control medicine. And then there's a reason why they won't let you travel, usually 7-10 days post-op. They want to see you afterwards, make sure that you're not getting any blood clots. Plus, if my foot or my leg is always down, it's gravity dependent. So if it's not allowing for good blood flow, they want you to get elevated, get that thing up. And if you're traveling on plane and those type of things, different pressures, you'd be more likely to be able to travel via car than you would by plane or anything like that. They don't want to see you get any DVTs. Okay, that's where you typically are going to see them. And we'll talk about it in a lecture, but what happens is that whole lower leg, it's common for them to have a big swollen knee post-op, right? It's common for them to have some fluid down here in the leg, or they start getting some pitting edema late. You can put your finger in here and it leaves an imprint. That's what pitting edema is, okay? But if this thing is swollen and almost like the skin is bright and shiny, okay, you're thinking, that should be a red flag for you. Also, they might lose some dorsiflexion, pull up. That might get weak on you. They might get some numbness down in their foot. Okay, where we've seen these in the upper extremity, all of a sudden their whole upper arm is just swollen for no reason. And you're like, what's going on with that? And you think there's a clot here because it just starts to pool down here in the lower leg, or in the upper arm. Same thing here. And it's gonna feel heavy and it's gonna be painful. Where the pain's gonna come is here in the back of the calf. So my Homan's test is you would be sitting, scoot back that way just a little bit, like your legs hanging off the edge here. So my Homan's test is I'm going to dorsiflex their foot, okay? And while I do that, while I dorsiflex, that's the Homan's test, and Pratt's sign is I squeeze. In both of those, I'm looking for pain in the center of the calf. So I'd have to have those other things to go along with it, right? Nice shiny skin, meaning that it's tight. Okay, it's filling up, those compartments are filling up with blood and they're not getting circulated, okay? And the other thing is some tingling numbness or just a heavy feeling in the leg, pain in the back of the calf. So I dorsiflex, Homan's test, Pratt sign, squeeze, okay? Kind of a combination of those two together, okay? So what we're gonna do is let's split off in our groups